Thank you very much for inviting me today. So 2 new things. First time with a microphone, never done this before. And first time at a patient group meeting like this. I've done British Sarcoma Group where there are certain bits that patients can come into, but I've never done a whole patient day, so I'm really excited. And thank you very much, Judith, wherever she is. So Judith asked me to come and talk to you about what a clinical nurse specialist is and what they do and what we do at the Christie. So that's what I'm going to do. So I am actually a clinical research nurse. So kind of slightly a clinical nurse specialist, but mostly focused on clinical research. I work just down the road at the Christie. I look after all the sarcoma patients, so bone and soft tissue and GIST patients. And I mostly look after patients on clinical trials. So I make sure that they're looked after properly. I make sure that the doctors stick to the protocol and they all get all their investigations and things done at the right time. But I also, as all the Christie patients will know, do see off-study patients and patients that aren't on clinical trials. So, next slide, please, David. So this is just a bit about what I'm going to talk about today. This is the agenda, really. I was going to just talk a little bit about my experience and what's led me to work in sarcoma. As I was preparing for this session, I've kind of got a little bit of a quote and a definition of a nurse specialist that I thought was really good. So I thought we'd have a little look at that. But what I'd like you all to do, because I don't know very many of you, is to think about your experience and think about whether you've got a nurse specialist, whether you found that useful. I'd like you to think about what they do for you, your nurse specialist, what their roles are. And I was kind of hoping that instead of me just stood up here talking, that you'd all join in and we've got some paper and we can brainstorm and do a few things that you can shout out. I'm going to talk a little bit about toxicity management because that's a huge part of my job, looking after patients, the GIST patients on treatment. Talk a bit about the Christie service, what we do down the road. Be really interesting to see what your experiences are and what you all do at your different hospitals. And of course, Dr. Leahy will shoot me if I don't talk about clinical trials. So I'm going to talk a little bit about clinical trials. Not so much the clinical trials that we're running, a little bit about that, but just the sort of whole philosophy of clinical trials and how important they are. So I trained in Bristol in the 80s, and I moved up to oncology in the Bristol Oncology Centre in 89. And I worked there for I moved up to Manchester in 1996. I met some bloke and I moved up to Manchester. And I started working at the Christie, up on the medical oncology wards at the Christie. So I was a chemotherapy nurse through and through, worked all around the hospital. And eventually, in about 1999, I decided that I wanted to specialise. So I wanted to go into clinical research. I went to join the upper and lower GI research team and loved it. I loved clinical research. Loved the pace, loved treatment, loved working with new drugs, loved having my own patients because I'm a bit of a control freak. So did a few different disease groups in the Christie. I worked in renal, GI, and then I went off to Australia for a bit, and I did a bit of everything actually in Australia. I did some haematology. I wouldn't recommend that. That was not my thing. A bit of breast, a bit more GI, and lots of sarcoma. And I think really that's what really started getting my interest in sarcoma. I did lots of GIST work, and it was around about the time that imatinib was coming out. So it was a huge, exciting area in a disease previously that we'd had no treatment for. So I think that's what really caught me with sarcoma. So I came back to Manchester in 2007 from Melbourne, and Dr. Leahy had a job, so I went for the sarcoma team job. And I've been there ever since, really, like a bad penny. 2007, so that's 8 years I've been with Mike. And I love the sarcoma team. It's a great team. We're a very small team, but we have lots of clinical trials. We're a very active unit. Dr. Leahy's very interested in GIST. He is an expert, really. He does lots of stuff all over the country and, in fact, European and international. So, as I said, I'm a research nurse, but I also work in the nurse-led clinics at the Christie, and I'll just go into that a bit more detail later. I'm also a nurse prescriber. We're really lucky at the Christie, actually. We've over 60 independent nurse prescribers working across all the different teams, which means for us in the sarcoma team, I'm able to see my patients, and not only can I prescribe their targeted therapies, their imatinib or their Sutent or regorafenib, or in fact their trial medication, I'm also able to prescribe all the other supportive medications. Sorry, I feel like I'm putting my back to you over there. So I can prescribe anti-sickness medication, anti-diarrhea medication, anti-blood pressure medication, all those kind of things that you need when you come in. I'm able to do all those things as well, which makes a huge difference to our clinics and a huge difference to you, the patients waiting. They don't have to wait for the doctor to prescribe their medication. Thank you. Am I in anybody's way? Can you all see that? So when I was trying to think about what specialist nurses do, I thought this was quite a good quote, because there's quite a lot, actually, of different bits in there. So I'd like you to just kind of have a think about that, but also what your clinical nurse specialist, if you've got one, is to you, so that we can have a bit of a chat. So I guess they've got to be a specialist. You've got to have somebody that has been working in that area for a while and knows that disease group. So they're a specialist and an expert, an advanced practitioner, someone that's got good all-round experience but has specialised in that subject. Especially in a disease like GIST, where it's so rare, you want someone that knows what they're talking about and has got a bit of experience looking after you. It says that you should be able to work in isolation or as part of the MDT. I think that's really important, because although we work very closely as an MDT, we know that patients' outcomes are better if you're looked after by a specialist sarcoma MDT, and we've got lots of experts within that group to help us look after you better. Often you have to be able to work on your own, because you are seeing patients and you have to assess patients and sort out symptoms. Often I've got no doctor around, so you do have to kind of have enough confidence in your ability and enough experience behind you to be able to sort problems out on your own, despite being part of that team. So I guess the main thing on that for me, you can see because I've underlined it, is it's patient-centred. It's got to be patient-focused. It's got to be about you. It's got to be about us providing the best care possible to improve outcomes for patients. So it's no good if it's not effective for you. So I guess we could try and move on now and before I do the next slide, because I've put lots of bits up there that I think is the role of the clinical nurse specialist. But I don't know whether you just want a couple of minutes in your tables, or whoever sat next to you, or if you're really ready to start the day and shout out some things. And I'll just write a few things down. Have we got a pen, Judith, for...
Oh, yes.
I'm trying to work out where I can stand where I'm not putting my back to somebody. So I guess the first question is, have you all got clinical nurse specialists? Do you want to put your hands up and we can just kind of see who... And I bet yours is brilliant. So that's not very many, really, is it? I thought there'd be lots more of you that had clinical nurse specialists, and there would just be a few that didn't. I guess, there's lots of different types of nurse specialists too. You have, if most of you have had surgery, hopefully you would have met some sort of surgical nurse specialist that helped you pre and post-op through those sort of difficult few weeks and gave you advice about, the practical aspects of surgery. And then, obviously, once you're finished your surgery and you're handed over to the next appropriate team, that you have a nurse that is there that's looking out for you. But not many of you have, so that's a bit sad, isn't it?
I think we probably have, but we don't necessarily know.
So you've not met her, do you think, or him?
In our case, there's no ongoing treatment, so probably that's why. Sometimes I don't think it's necessarily spelled out.
I guess, though, you know, we do still have patients that are not on treatment that we still look after that would phone me if they had an issue, or I guess it's just knowing that you've got somebody there that's your sort of point of contact. That's often, you know, what's the most important, really. Yeah.
I think in some places there's teams, so you may not necessarily know exactly who, but you know if you
There's somebody.
If you phone the nursing team, then you'll get somebody come back to you.
Okay, that's interesting.
Mum couldn't account for that with how your job, what you do, but her peace of mind, bedside manner, fantastic compared to some of the specialists, and your team's amazing.
So I'm going to give Sue that fiver in a minute.
You recognise Judith?
I don't know. Yeah.
Judith.
Sorry, I think there was somebody.
I have a Macmillan nurse who's there any time, and I don't need to ring her up or anything,
Yeah.
but she hasn't got an awful lot of knowledge about
No.
GIST. Oh, sorry. She hasn't got an awful knowledge about GIST. You know, she's asked me to bring some stuff back with me.
Yeah. I guess the thing is, she doesn't really need to have an awful knowledge perhaps of GIST because, as I said, there's lots of different types of nurses that will support you at different points. And your Macmillan nurse, I guess, is someone, does she come and see you at home?
No.
So she's a hospital Macmillan?
Yes.
Right,
yeah.
Okay. Because obviously, you know, there are Macmillan nurses that will come and see you at home to help you with symptoms or financial, sort of social things like that. But, you know, I guess, see, I'm biased, and I think that to look after GIST patients, you need to know about GIST, really.
Yeah.
And whether you're on treatment or off treatment, you know, especially if you're on treatment, because, I mean, I'm going to talk about it a little bit further down. There's a few slides, how you manage patients on treatment and how you manage side effects. And I mean, I'm very lucky. I work at a very good specialist centre, and I'm kind of biased, I get, but I think that you all should have access to those kind of facilities.
Mm-hmm. Okay.
I find it very confusing when I go to a GP and he hasn't got a clue what I'm talking about.
Yeah.
You don't see the same GP, you know, in this day and age. And I gave him a booklet, and he really wasn't too mithered. He didn't like to be. So I flounder unless I come and see you and Dr. Leahy.
I think probably lots of people will find that, won't they? Because not just with GIST, you know, sarcoma is a very rare disease. Your GP may never, apart from PATS, may never see another patient with sarcoma or GIST. And, you know, GIST is the most common type of soft tissue sarcoma, but still it's very rare. So we often do have patients have that problem with their GPs. I mean, what we tend to do at the Christie is Dr. Lee has done lots of healthcare professional information that we send out to the GPs and to other people looking after you at home, just really kind of giving them a bit of a heads up about what it is, how we treat it, you know, what the expected outcomes of treatment are, and contact numbers, really.
Sarah, there's another question here, but I just want to ask a quick question. You say cost-effective care.
Mm-hmm.
What do you mean by that?
I guess when these days, with the current economic situation, everything has to be cost-effective. So I have to use my time properly to make sure that I'm looking after the patients in the best possible way. And cost always comes into, you know, funding, making sure that you're effective, making sure, and this is why this sort of thing is so great, because if we're doing something and it doesn't work for you, then you really need to tell us, because, you know, for example, if I sit in clinic all afternoon and that's useless, that's wasting an afternoon of, you know, a band 7's salary, and it's doing nobody any good. So I think that's what I mean by cost effective, that what we're doing is working.
Can I ask how long it is that nurse specialists have been widespread use?
I think that probably the clinical nurse specialist started in the 90s, actually. So at Christie, we've only had a clinical nurse specialist in sarcoma for about 2 years. Took us ages, actually, to get, and that's money, unfortunately. And because we're a rare disease, often, you know, we're forgotten. So, so I think around about the 1990s. And then more recently, clinical nurse specialists have kind of morphed into advanced nurse practitioners, perhaps. Nurse clinicians, I don't know if any have heard those sort of terms, where I guess because historically you would have always seen a doctor in clinic and the doctor would have seen you and examined you and prescribed you medication, whereas I can do that now. So that's different. Our roles are evolving quite quickly, and more often than not, many of you may see nurses that can prescribe your medication, that can examine you, instead of seeing the doctor.
Hello, it's Michael Sayers,
Hi,
a
Michael.
Dissupport trustee. I'm under the Royal Marsden, and whenever I ring the Royal Marsden because I've got a problem with my medication or side effects or whatever, it's always I ask for a sarcoma unit, and it always goes through to the clinical nurse answering machine, and it's the clinical nurse is the first point of contact. So I'm slightly surprised that there's not more people like you. When you asked for the show of hands, there weren't more people putting their hands up, because I would have thought that's how quite a lot of the hospitals actually work.
Well,
Clinical
yeah.
nurses taking the first inquiries from the patients.
Yeah, and actually I've got a slide further on that talks about a little bit about the multidisciplinary team and where nurses fit into that. And I don't know if anybody have heard of, key workers, and I'll talk a little bit about that as well, which is what nurse specialists are. They're key workers. So you should all have a point of contact at your specialist, whoever's looking after you should have a phone number where if you can't talk to someone straight away, you can at least, Michael, leave a message and they'll ring you back.
Another point on cost effectiveness, not being too personal, but I'm sure you're not paid as much as the doctors are. So your time doesn't cost the NHS as much as the doctor's time.
Exactly.
So it's actually very cost effective for the hospital to employ you, because it gives the doctors more time to see the people they have to see.
Exactly. So the doctors are freed up, if you like, to see patients that have got more complex needs, to see patients that are more unwell, that newly diagnosed patients, for example. Our GIST clinic, we run in sort of tandem. So there's always a doctor around, but they don't always see our GIST patients every time they come. Quite often it's me or Anne, the nurse specialist. And you're right, absolutely, that I'm cheaper than Dr. Leahy. So, yeah.
And presumably, if you're concerned about a patient, you then refer them.
Yeah. I can. There's always somebody I can ask.
Yeah.
And I guess I think that's why the nurse specialist roles were evolving, so that nurses can prescribe and can do all these things, because we are more and more taking over things that doctors historically did because of cost.
Yeah.
And
do you have extra training for this?
Yeah.
And do you ever wish you were a doctor?
No, I do. No, I don't wish I was a doctor, because I'm not clever enough. Because especially in sarcoma, it's so complicated. But I do really love clinic, and I love clinical. I love being with patients and sorting out issues and examining patients. So I love that, and that's why clinical trials is great, because as well as doing all that, you're using new drugs, which is fab.
Yeah.
Hang on. I think it was 50 leaflets from one of the meetings we had. And I gave a couple to my GP, and he was absolutely thrilled to bits. He made sure all the staff knew all about it. He actually is on first name terms with my surgeon, Mike Lay. They've worked really well together as well over my case. And I took them to the Macmillan people as well and gave them Macmillan pieces. But I actually took most of them to Dr. Leahy, and he was absolutely thrilled to have them.
He'd never seen them.
He hadn't had one when I took them. I think it was from the Bristol, which meeting was it when I took them? It's quite a while ago. But I was thinking, it'd be a bit, think I'm stupid. And you could see he was really, really pleased to receive them, as was my GP.
I think it's all about awareness. It's all about education, and it's all about just letting people know, because I'm teaching my grandmother to suck eggs. Only you know how frightening and scary that is, to be diagnosed with cancer. And to be diagnosed with a cancer that's really rare is double whammy, isn't it? Because nobody until you join something like this has got that. And the information that you can find on the internet can be really dodgy. So, you know, I think the more that these kind of support forums run and the more people join and the more awareness there are, then it can only be a good thing. So, can anybody think, and I'll do a bit of writing, just what they think their nurse specialist offers and what they think the role is, and just shout out some ideas.
Availability.
So should we say expert?
Yeah.
Yeah, good. Because the last thing you want to do is go along and you think, crikey, what does she don't know what she's doing? Yeah, so some support.
Yeah.
Makes you feel like a patient or a person rather than a number.
Hopefully.
When I said about confidence, I meant you've got confidence, but you instill that into the patient.
Yeah, which I think is why when you think about a nurse specialist, you need to have somebody that's got a bit of water under the bridge, so to speak, because if you haven't got confidence in your experience and all the stuff you've done before, then that projects, I think.
Yeah.
Yes.
Yeah.
Not involved emotional support. In other words,
Yeah.
emotional support, but not yourself personally getting.
Yeah.
Yeah. Yeah.
So somebody that's what's the word for it?
Detached
Yeah.
emotional support.
Because often, you know, it's easier to talk to somebody that isn't your family or your friends,
Yes.
because you can't always say the things that you want to, perhaps.
Yeah.
So if you've got somebody that you can kind of offload that stuff to and not worry about saying that, that's
Yeah.
important, isn't it?
Yeah.
What about down the back there? You're all very quiet over there.
Provide an important link between the patient.
Brilliant.
Yes.
So it's like liaison, isn't it, between all the different, perhaps all the different people that are look after you, surgeons and GPs and things. Mm.
I kept it together when I come back speaking to my oncologist, but then once he left the room, I kind of fell apart. And she
Yeah.
was there to support me.
Yeah. And often I think if you've got a good nurse specialist that you know and that has been with you since, you know, many nurse specialists are there right from the point of patients being presented through the MDT. So they kind of know you and they know what you're like, and they know, you know, when you come to clinic, they can see. And then you don't need to tell somebody, they just know you.
Can I ask a question of the room? When Sarah asked you to put your hands up as to who has got a nurse specialist, very few people put their hands up. Following what you've just said and what we've just put on that board, how many now will go and find out who their nurse specialists are? Have a show of hands as to who is now going to go see who their nurse specialists are, and if there is one. The point I'm making is that maybe the people in the room didn't realise how much you can add and help.
Mm.
Now they can. I'll certainly do it. Go and find out who my nurse specialist
Good.
is for support and advice.
What if we don't have one, or what if we can't get one? Because it's quite depressing seeing all that. We have nothing like that at all.
Church Hospital.
Whereabouts are you?
We are at King Edward's in Windsor, and we tried to go to Royal Marsden. We couldn't get a second opinion, which is just scandalous, really.
So, I mean, perhaps I could talk to you after, because obviously we don't want to, you know, talk about all your ins and outs in the whole room, but I'm sure there'll be some way that you can access some, and I'll have a chat with you after. We could talk about perhaps who looks after you and find a sort of
a lot of people are not treated at centres of excellence, which are necessarily a larger and more experienced group of people. They can't afford a nurse specialist for rare diseases. So do you, as a Manchester area specialist, look after anyone from any surrounding hospitals?
So
we're from Sheffield, and Sheffield does liaise with the other smaller hospitals in the area. I just wondered if it was like
And do you have a nurse specialist at Sheffield?
It's my husband, yes.
I've had one since 1989.
Right.
I don't think you were cold.
No.
Cold. No, sorry, 1999. I don't think they were called business specialists, but they're very all the functions that you're describing.
So you've got a nurse, somebody there that you can contact. I think you're right. Sorry, I think you're right, and what I don't want to sort of stand here and look as if that we're fantastic and we, because I appreciate that not everybody's looked after in those kind of things. The only thing I would say is that that's when this kind of forum is really important, that you can talk to each other and people can offer ideas about things that they've done or who they've contacted. So that's really important. And also I actually, I look after, we don't just look after patients in Manchester, we look after patients across the northwest. We've looked after patients up as far as Scotland and down as far as Devon. So we do see lots of different patients. And actually I do quite a lot of teaching and stuff to nurses that aren't sarcoma nurses, I do a lot of stuff for upper GI nurse specialists. I was at one recently with up in the northwest, and they asked me to go along and talk because they see increasingly more patients with GIST, and none of them had any idea about what GIST was or what the implications were or what treatment was offered to patients afterwards. So I think they kind of just wanted a bit of a heads up about some of the things that happened to the patients post-surgery. They're very good at offering all the kind of support you need pre-surgery, because often, and I don't expect you all to put your hands up and tell me, but often many of you have had very life-changing surgery. So you need lots and lots of specialist support at that point that I know nothing about, all those kind of things that you need with surgery. So it's kind of everybody linking in at different places, really.
I was just going to say that in answer to the lady's question over there, is Just Support UK, we can, I think, look at clinical nurse specialists around the country and put them in either on the website so that people have a way to contact somebody in that.
There is a National Sarcoma Nurse Forum that started a few years ago, and that meets once a year, and that is a group of nurse specialists that, like me, look after all types of sarcoma, but would look after GIST patients. So I'm sure there's a way of kind of getting access to that information. Martin.
Yes, well, I'm a patient at the Chris's, Dr. Lee, he's and yourself, fortunately or unfortunately, whichever way around. But surely in this fight with the GIST, we need as much support as we can get. So I'm surprised when people, for example, say, well, their doctor doesn't know about it. Well, the GP, by definition, has got so much to think about. My GP, I'm the only GIST he's got. But there was a government-led scheme last year whereby people that maybe have got a GIST, there's a facility where they can have a nominated individual at the surgery, obviously a doctor, and when they ring up, they'll either speak to him or he will ring them back within 2 hours to discuss any problem they have. And again, it sounds as if people aren't familiar with that, but surely in this fight, you avail yourself of everything that is there.
Absolutely.
And this, in fact, my GP's moaning the time he's spending actually getting people involved in it. And the object is to stop people going, not to stop, but to try and eliminate as many people going into hospital. So he's there to give you advice. But as he said to me, if you know more about GIST than I do, but if you have a heart attack, then you get an ambulance, obviously. But so I'm surprised that people aren't, almost demanding specialist help. And if it's there, well, surely you avail yourself of it.
I guess it's perhaps that people don't realise it's there, or at times of stress and diagnosis, people they have so many things going on. And I guess, people trust that the doctors, the specialists that are looking after them are going to do the best job that they can, so they probably think, well, perhaps I don't need any other. But we always encourage our patients to keep in regular contact with your GP and to, look around and get information. We give all our GIST patients the info for this charity and Sarcoma UK.
Fine.
Anything else? Any other? I've got another slide there, as David. I just put a few things up that I thought were just a few.
Do you add to that list, do you become a medical friend?
Yeah, I will. On that one. So there's not much else really that you said different. I guess for me, it's more about some of the things like audit, so looking at what I do and asking you if it's effective, because there's no point me doing it if it doesn't work for you. So you must always be honest with us and tell us if you think something's working or not. Education is a really big part of my job, talking to patients about what's happened to them and what facilities are available for them, and if they're going to go on to treatment, what treatment they're going to have and what to expect. Patient advocate is a really important thing, I think, for me. When you're diagnosed and you've got all this going around in your mind and you're scared and you're trying to get information, it's really important that you've got somebody that's there for you and watches your back and is able to make sure that your interests are paramount, really. And lots of the others you've got there, open and honest, somebody that's available, somebody that's supportive. Thank you. So I guess I've put the answer up now, but I wanted you to think about whether you thought a GIST and a sarcoma nurse specialist was different to being a nurse specialist for other types of cancer. I don't know whether any of you have got any thoughts about that, really, whether you think it's different depending on which disease group you work in.
My nurse is actually called the upper GI nurse, but she knows about GIST.
Yeah. Yeah, which is okay, because as I said, I've often talked to upper GI nurses because they are seeing lots more, and patients are often treated out in
Well, it's only a district hospital.
Yeah.
Who liaise with yourselves at Christie and with the QE in Birmingham.
Yeah.
But she actually, even though she's called the upper GI, she's always been there when I've seen the oncologist.
And often, the upper GI nurses do look after the GIST patients. That's quite common.
It probably sounds a bit silly, but a lot of people that come to you diagnosed with GIST will be having various treatment for other illnesses they've got. So you've obviously got to be able to know the interaction of the various drugs. I suppose that comes with, knowledge and things, because a lot of the drugs don't interact right with the, So I thought that was and then you can get another illness once you're into GIST and all the drugs, then your drugs have to be changed again.
Yeah.
So that's important.
We have patients in our GIST clinics that have been on imatinib for more than 10 years, and things happen to people in 10 years. They have, they get diabetes, or their blood pressure goes up, or they fall over and break their leg, or, it's not just a one-stop shop. You have to, when you're looking after a patient, you have to consider the whole patient and everything that goes with that patient. And also, I've got a slide talking about how important it is to look at patients' past medical history and drug. So I guess to cut to the chase, I think it's, for me, and I can only talk from my experience, it's much different looking after sarcoma patients than looking after other types of patients with cancer. And I think probably because it's a rare disease group, because there's information can be difficult to get, because there's often a lack of support. So all those kind of things I think our patients need quite a lot of help with. And I'm not talking really about GIST, but generally sarcoma, our treatment options available in our cupboard are quite small compared to breast cancer or colorectal cancer. So I think we're limited.
Yeah, no, it was just, as you were saying, that different disease groups are very different. I went through the breast cancer journey 12 years ago, and that is totally different because it's slick, it's operational, your clinical nurse specialists are there, even the diagnosis of it, you know, you go, you've got a lump and you're in the system. Actually getting a diagnosis for a GIST is totally different to breast, and the journey through the GIST is a lot scarier because you haven't got that support. And as you say, there's not the information out there and all those sorts of things. And I think that when you're looking at it, when you look at the breast cancer journey, women are gobby, women have got all the necessary support out there.
Yeah.
And I think that is a really good standard to aspire to.
But I think as a group, and I don't want to offend anybody, but I think you're really gobby. You're a great group of patients because you're very much like breast cancer patients, I think. You're just in a smaller group. You're a bit more of a minority. I don't want to say a minority, but but you are very, politically aware, you're very supportive of each other, you're very aware of what's going on around the place, and look at the fantastic work you've done as a group of lobbying with the recent drug regorafenib. So I think you should all deserve a big round of applause because you are a very proactive group of individuals, especially for something that's so rare. I think breast cancer is just more common, isn't it? So, okay, next slide. So I just want to talk really briefly about the kind of journey and the pathway of patients. So when they're diagnosed and where the kind of oncology nurse specialist fits in. Because I kind of think that we are one of the very few people that are there right from the very start, right from diagnosis at the MDT, where they look at all your scans and slides and tumour blocks and all those kind of things. Your nurse specialist or a nurse specialist is generally there. And generally, that nurse specialist is identified as a key worker, as I said. So when your case is presented through the MDT, the team meeting with all the surgeons and the radiologists and all the experts there, and that is absolutely what you should expect when you're diagnosed with a type of sarcoma, that you are seen through a specialist MDT, specialist sarcoma one, that you're assigned a key worker straight away. And that key worker is generally your nurse specialist. And right at the start, that person is there as we said, at the point of contact, someone that you can ring, someone we've talked about all this, someone that's there to liaise between all those surgeons and radiologists and your GP and the Macmillan nurses and your work and your kids and all those kind of things, just to kind of link that all together really for you. That's really, really important that you've got somebody. I've talked about patient advocates, so I won't go through that again. This is when you talk about the bit there that says about patient education. It's really important when you were saying, when you see your oncologist as a new patient, that your oncologist takes a really good past medical history from you, because often patients have other health issues. They might have problems with their blood pressure, they might be diabetic, they might have asthma, they might have all sorts of things wrong, but then they might be on all sorts of medication. And if you're moving forward and giving any patient treatment, if you don't know what's wrong with them before you start, you can't work out further down the line what's a toxicity from drug and what is a predisposing problem. So it's really important that you take a good medical history, and that really goes back to good medicine and good basics. And that also someone sits down with you and says, what medication are you on? Because a lot of the drugs that we give for GIST do interact with other types of things. So we need to know what you're on before we start, so that if you're on something that's going to interact with the drug, we change it or we swap it for something that won't. I always tell my patients to, if they go and see their GP for a chest infection or any issue and the GP gives them anything, just to give me a little ring and ask if that's okay. Because what we don't want is you coming back into clinic and he'd started you on a medication that's going to affect the imatinib or whatever drug you're on. So it's really important that someone does that at the start. I'll just talk briefly about managing toxicity. It's really important to be proactive, I think, in managing toxicity, because looking after patients with GIST on therapy is very different to looking after patients on chemotherapy, for example, because, you know, standard chemotherapy for soft tissue sarcoma is drug for 6 cycles, which is over in about 18 weeks. And in amongst those sort of 6 cycles of chemotherapy, there will be times where you feel rough, but there will be times when you feel okay. And so it's a bit sort of transient, the toxicity. So it's much easier to manage, I think. Whereas toxicities on these kind of drugs, and if you can imagine that if you're on these drugs for 10 years or more, they can be very chronic and sometimes quite mild, but niggly side effects that affect your quality of life. And it's really important that we know what those toxicities are and that we look out for them at the start and we nail them before they get to be big problems. Because what we want is for you to stay on that drug for as long as we possibly can. And you're not going to be able to take a drug for 10 years that makes your feet so sore that you can't walk, or your mouth so sore that you can't eat. So, you know, being proactive is really important. And also you telling us and being honest with us about the side effects of the drug is really important. I spend a lot of my time troubleshooting, either in clinic or on the phone with side effects. Patients ring up and ask, you know, I've got this and what can I do? And, you know, those kind of things. I spend a lot of the time, which is what Judith was saying, was about freeing up the consultant's time to do other things, because they couldn't possibly do all those things as well. And that's really important, that you have somebody that you can contact. And, yeah, to coordinate your care, really. Someone there making sure that it all runs kind of smoothly.
Is there when you change someone's medication, is there an automatic feedback to their GP, for example, so that next time you go to the GP, you know, he knows or she knows what's happened?
Yeah, we always write to the GP if we're changing anything, actually. Or if, for example, I needed the GP to change something and you were at home, if you phone me up and your anti-sickness wasn't working and I wanted to change it, then I would just fax a letter over to the GP. So we would always let them know if we're changing. Okay. And also, you know, a good doctor or a good nurse that you see in clinic will ask you if your medication has changed since the last time you came in or if there's anything new.
I use the same pharmacist all the time, and she knows about the GIST and the Glyvec, etc. And she would, if I go in and I say, am I able to take such a thing, or I'm going on holiday and I need malaria tablets, she will always look and make sure that they won't go against any of the treatment that I'm given from the hospital.
There's actually a really good website, Pat, that you can, I can give you the link, I can tell you the name of it, that you can just click on and it tells you, it lists all the drugs that are contraindicated with the CYP450, you know, the imatinib. And
I mean, I always take that wherever I go, but, you know, it's nice to know that the pharmacist knows and understands and will check as well.
Absolutely.
It's just an extra backup.
Yeah. Sorry, Michael.
Yeah, the principal reason that I am here at all, I mean at this conference, is that when I was first diagnosed, I thought, at first I took the man thing, I can handle this, it's great, it's you know. But after about a year, I realised that I didn't actually like not knowing if there were other patients anywhere with the same as me, or going through the same treatment or what. But I had to, so I actually asked at the Royal Marsden, you know, is it possible to be in touch with other patients in any way? And so I found out about what GIST Support UK was then. And I was just wondering to what extent is it written into your job description or into your training to encourage patients to, you know, to get in touch with groups such as ours?
I think it's really important, and I think we always, when we have a new patient coming, we give them a patient pack, and depending on what type of sarcoma surface, a GIST patient, and they get information on support and somewhere they can look for information. So they always get GIST Support UK information and Sarcoma UK stuff. And then they get, you know, depending on what treatment possibly they're going to have, they get information on that as well. So it's really important.
Yeah. But is it actually sort of formally part of your training that
I guess
you have
if
to
you
do
were,
this?
I don't know whether it's in my job description somewhere that says...
Because it wasn't until I asked that I got put in touch with a patient advocate group. It was the kind of the forerunner to GIST Support
I think,
UK.
so I guess probably it's not formal, but it goes back to holistic care and treating everybody as an individual, doesn't it? So I guess it's down to the individual, whoever you're seeing, to them say. Because some patients don't want to. Some patients don't want to talk to anybody else, see anybody else. They just want to come to clinic and go home. And other patients, you know, do. I think you just have to treat everybody on an individual basis.
Absolutely. I'm just saying there's no harm in suggesting it to every patient.
No, absolutely.
Had they thought about this?
So I'll just crack on because I think I'm going to make everybody late for their dinner. So just a bit about the Christie GIST service. We've a specialist medical oncologist, Mike Leahy, who's talking this afternoon. He's very interested in GIST. He does a lot of GIST work across Europe, and we participate in lots of clinical trials. We've got a nurse specialist, and we're an active trials unit. I'm the research nurse. We actually have a database of all our patients, and we have a trials meeting every couple of weeks. And if we have new studies coming up, we go through our database and look to see if anybody's going to be eligible for that study. And we always talk to patients or approach patients about clinical trials if they're going to be eligible, and let people decide if they want to participate. We have a specialist sarcoma MDT. We have, as I said, the nurse review clinics, which run alongside the normal clinics. So our GIST patients who come quite regularly will know that they don't always see the doctor every time. It alternates between the doctor and the nurse, but there is always a doctor around if you need somebody. And we have 2 GIST clinics a week, and that's a real mix of GIST patients. So that's some patients that are in follow-up that aren't on treatment, that have had surgery and are free of disease. We have some patients on adjuvant imatinib who we give adjuvant imatinib for 3 years, so they come to our clinics. And we also have patients with metastatic disease who are on various kinds of treatment. So that's just a bit generally. Thank you, David. Next slide, yes, thank you. So this is what the current treatment really, adjuvant imatinib for 3 years. I'm sure you're all aware of that. And then for metastatic GIST, we have our first lines imatinib, sunitinib and regorafenib. So our patients have access to all those drugs now, regorafenib, thank goodness. And also access to clinical trials, really, really important, I think, that you have access to clinical trials, because it can open up, not only does it, open up a new avenue of treatment for you and offer you a potential extra line of treatment, but, you know, if it wasn't for patients participating in clinical trials, we would not have imatinib and we would not have sunitinib or regorafenib. So it's vital that that people participate in these studies so that we can advance our practice and get access to new drugs. Thanks, David. This is just a quick slide about talking about toxicity, really, and management of long-term patients on long-term therapy. And I guess the aim of the game is the middle big red circle, which is what we're aiming to do as a group of medical professionals, is optimize the long-term clinical benefit for you. So if we find a drug that works, we want to keep you on that drug for as long as we can. But whilst we're doing that, we're very mindful of making sure that, as I said, you know, the toxicity every day when you're taking a drug is tolerable. So you are able to manage that drug with not too much of an impact on your quality of life. Now, I'm sure that there will always be an impact on your quality of life, but as I said, we don't want it so awful that you can't get out of your house because you've got rampant diarrhea, or you can't walk because your feet are so sore. So it's often a balance, and especially when you start treatment, I'm sure you all know, of trying to manage the toxicities with your activities, really. We want to minimise dose reductions if we can, and we want to minimise interruptions, but those are two really important parts of treatment. So don't ever worry if you have to stop drug for a little while to let a side effects settle down, and don't ever worry if we have to drop the dose a little bit, because not everybody can take the same dose, and patients often worry, I think, and often perhaps aren't honest with us about the extent of their side effects because they worry that we're going to drop, and sometimes you need to, because if you want to get long-term benefit out of a drug, you need to just tweak it a bit and go down a little bit with the dose. The way we do this is the outside circle. As I said, it's being looked after by a group of healthcare professionals who have an interest and some knowledge in the field that you're being treated for, and that are able to recognise symptoms early and try and sort them out quickly, because it's a nightmare when you have to do it further down the line and then it takes that much longer. So it's important that we recognise those symptoms and actually try and sort them out quickly, but it's important that you're honest and tell us as well if you've got issues. Thank you. So just quickly about clinical trials. Obviously, as I said, it's about development of new drugs. It gives you access to new drugs. It gives us access to using these new drugs, which is brilliant. It's about gathering information about those drugs and how they work, and looking at the profile of the side effects, and efficacy if they work. And then it opens up kind of a whole new aspect of clinical trials, which is if it works, then we start thinking about why is it working, and looking at that particular group of patients that it's working, and then we start looking at things like mutation analysis and biomarkers and tumour blocks, and try and work out if we can nail down why it's working better in that group of patients than in another. And then that changes practice, that's practice changing. So I would always say, please consider a clinical trial. Please always ask when you're seeing if you're getting to a point where perhaps treatment's being changed, or when you're a new patient, or any of your friends that are going that as new patients, that they always ask about a clinical trial, because I know it's a difficult time. You've got lots of information to consider, but it's important that you at least consider a clinical trial. Has anybody, just a quick show of hands, because I don't want to interrupt on James, has anybody ever been on a clinical trial? And offered a clinical trial? Sorry, I can't hear you.
I know Michael Sayers was offered one. He's not in the room at the moment, right, okay, but he was offered a clinical trial.
What's your thoughts about clinical trials? Do you think they're good, or do you think lots of people worry that they were going to use them as guinea pigs?
I think a lot will depend on the nature of the clinical trial, won't it? I know some years ago they were trying to get a clinical trial going to see whether patients who'd got secondaries in their liver had surgery or not. And they just couldn't recruit patients because all the patients said, I want the surgery. If it's possible, I want my tumour removed. They just couldn't find any patients who were prepared to not have the surgery, so the clinical trial never happened. If it's a clinical trial, for example, of taking imatinib for 1 year or 3 years, that's a much easier decision. I think that's recruiting well, and it would depend on the nature of the clinical trial. If you've come to the end of all the normal treatments, And it's a completely different ballgame. And I think it depends on, it's very much an individual thing, isn't it? Whether you want to try a new drug as an experiment, whether you're willing to do that. And I don't know what I'd say if I were in that situation.
I've been on a clinical trial since 2001, and I'm all for it, because, just to put it in a fairly light-hearted way, they look after you so carefully. The last thing they want is for you to die from something else. So they're always scanning you and asking you what's going on and all that kind of thing. So I was on the trial for imatinib, so it worked. But of course, they won't all work, but you will get some good care in between.
One point which kind of is relevant to the clinical trial, but also to the availability or existence of specialist nurses. We're based in Bristol, and when we were being dealt with by the paediatric nurses, obviously they knew us as if we were part of their family, and although they weren't GIST specialists, they were very, very focused on care. When we transferred to adult care, we did find it a bit odd to begin with, because we'd turn up at clinic and all the nurses seemed to be wanting to engage with everyone else but us. And after we'd been probably for about 4 consultations, we asked our doctor, you know, why haven't we got any kind of specialist nurse? And the answer we got from the group was that it was because we weren't on a clinical trial. So the reason they were so focused on everyone else is because they were on a clinical trial and we aren't. But the next time we went, we were then introduced to a nurse who we can contact, who is learning about GIST by using our documentation now. So they would like to help, but they don't naturally have that capability there. But I think they'd like to learn. So if you don't currently, what I'm trying to say is, if you don't currently have that facility in your hospital, or it's not naturally being offered to you, potentially you can encourage it to happen by saying, well, you know, we hear that other places have these specialist nurses. We've got some documentation here. Is there a nurse that is willing to, you know, learn more about it and get more involved? Is a possibility.
Well, that's how we got a nurse specialist.
Yeah.
With patients, you know, writing and us just continually saying we need a nurse specialist, and that's how we got it in the end.
Yeah.
I'm on a clinical trial, but it's not GIST-based. It's glutton for punishment, it's prostate cancer. But that, I would echo exactly the point we made earlier, that you do get far more contact with your consultant, far more frequent, and to that extent, it's highly beneficial.
Anybody else? No. Okay, I think this is the last bit now, the last run before dinner. Jane? Yes, please. So just quickly, this is the current, at the moment we're quite quiet on the GIST front with clinical trials. Our current metastatic study that we're running is so a first-line study looking at imatinib versus masitinib. That's ongoing. And we've got a few things now coming in the pipeline. There's a big quality of life and EORTC study coming, and the alt-GIST, which is, I think it's come out of the French group, where they're looking at first line, so patients are either going to take imatinib, alternating with regorafenib, and then versus imatinib.
How would you get to do a trial?
How would you join, enroll and join?
Yeah.
So you would ask your consultant that's looking after you what clinical trials are available, and if he has some clinical trials, he'll give you the information. You can look on this website. So I think the GIST UK support website has got a little bit about clinical trials. Sarcoma UK has got a link to the trials that are going on across the UK. And you can ask your consultant if you want to.
I did ask them and they didn't reply back to me.
Right.
Yeah, we keep asking them.
So you're absolutely entitled to a second opinion, and you're absolutely entitled to go somewhere else for an opinion for a clinical trial. We often see patients that come from other places, because to be honest, we don't always open up every clinical trial in every area, in every hospital. It would cost too much money and take too long. So sometimes, you know, for example, we'll do a study in Manchester that Sheffield's not doing, so Penella will send patients over to us, or, you know, we have patients, you know, if you're thinking about some of the more rarer types of trials, sometimes it might just be Marsden and Manchester, so people do travel. I'll have a chat with you afterwards.
Okay, thank you.
Next slide, please. So just quickly about the benefits of the specialist nurse. Obviously, our relationship, I think, is very different. My relationship with my patients are very different to Dr. Lee. His, I know my patients, I think, not better, but I guess, you know, I see you more often, I talk to you more often, I know what problems you've had, I know about your support systems and the kind of things that go on in your life. So I tend to have a bit of a different relationship, and I think that's a good thing. Your specialist nurse is there to offer education and support to not only you, but also your family, which is vital. Symptom management is really important, and as I said, just someone that's your key worker. Thank you. Next slide.
You never hold my hand.
I'll ask Dr. Leahy to hold your hand next time you come. So just in summary, really, obviously soft tissue sarcoma is rare, and GIST is the most common form of soft tissue sarcoma, but it's, you know, it's very complicated. There's lots of different types, and it requires a collaborative approach for sure in managing patients with GIST. The MDT, you need to go through a specialist sarcoma MDT, and that MDT needs to be patient focused, because it's got to be about you and making sure that you get the best possible care and the best possible chance. And that goes from the best possible surgery right the way through to the best possible therapy. Obviously, we've got lots of oral drugs around now compared to 10, 12 years ago. The sort of future generations of all these targeted drugs are coming through. Options for you are increasing. GIST is generally a very well-supported area of clinical research for companies. There's often lots of clinical trials, and I think nurses play a huge part in looking after patients on targeted therapies. I think that's it. Thank you. You've been brilliant. I knew that you'd all